But my name is Carol Wonke, and I work for Sharp Healthcare. I'm the Vice President of Post-Acute Revenue Cycle and Managed Care Operations, and I'm also the Board Chair for this year, first time, so glad to be here. And it's my pleasure to introduce a panel who will talk about cracking the nut on POLST registries, and Cothren is going to be our moderator. Rim?
Yes.
There you are. Thank you.
Thank you. Well, thank you for coming back this afternoon. My name's Cothren. I work with the coalition. Really got involved with them around the POLST e-registry pilot program. And that's going to be the topic, not only just the pilot, but what's going on with electronic POLST forms for this afternoon. We're going to have two panels. Talk first about some of the business aspects and then later about some of the technical aspects. And although I've got a few questions that I've lined up for the panelists here, I'm hoping that this will be more of a conversation. So if you want me to shut up especially, then you should come up to the microphones and ask questions since we get people a chance to kind of kick things off. So for our first panel, I'll introduce people just very briefly for those that don't already know who's up here. Abby Dodson is the director for the Oregon POLST Registry and also is heading up the evaluation for the California POLST e-registry pilot program. Sitting next to her is Pat Frost. Pat is the director for Emergency Medical Services Agency and Contra Costa Health Services. Next to her is Mark Branning. Mark is a consultant with the San Diego Health Connect Health Information Exchange down in San Diego, is one of the pilot participants. And Mark specializes in integration with EMS services and helped out a lot with the POLST program there. And then finally at the far end is Dr. Elizabeth Mahler, who is the Vice President for Clinical Integration at Sutter Health. Abby, I'll start off with you, and if you can just give us a few opening comments about your experience with POLST, electronic POLST, and maybe a little bit about the pilot.
Yeah. Hi, can everyone hear me okay?
Okay,
keep going. Oh, that helps. Like Rim said, my name is Abby Dodson, and I'm the director of the Oregon POLST Registry. As you know, Oregon has had a POLST registry for about 10 years now. We're hitting our 10-year mark. I have actually been with the registry for only about 10 months, so I'm still really new to palliative care, and I actually have a basic science background, so none of it seems to translate. But I got here in a roundabout way. I spent a couple of years in business development and digital health innovation, and that seemed to transition really nicely into running the POLST registry and the database. I'm also a research assistant professor at Oregon Health and Science University, where I conduct research on the impact of the program. So I came onto the California POLST e-registry pilot about halfway through, and I think the overall lessons learned are that, first of all, California is very passionate about having an e-POLST registry, and there are a lot of stakeholders and champions that are pulling for it and helping to make it happen because it's a lot of work. But also California is big. California is really, really big. So implementation is key, and implementation isn't going to be a straightforward answer. I think I'm going to talk about some barriers in our question and answer session, and I'd be happy to answer any specific questions that the audience has.
All right, thank you. Pat, you want to talk a little bit about your experience with electronic POLST?
Yeah. Can everybody hear me? Okay, great. Okay. Well, let me start by telling you what an EMS agency is, because most people have no idea what we do. We are the local emergency medical services regulatory body in the county, and we are responsible for all of the medical oversight for the pre-hospital care that is done in the field. And also have an important role in terms of facilitating data exchange, as well as evaluating the quality of that care, and also creating systems of care. So you have like trauma systems and STEMI systems and stroke systems, all in your communities most likely. We are the regulatory agency with the authority and the powers to create those systems. So we play a role as a facilitator in many of these programs, and that is what brought us to the table here. In my community, we serve about 1.1 million people. We have over 105,000 responses on 911 a year, and basically we're brought to the table as part of SB 19, Senate Bill 19, to participate in the POLST e-registry as part of the project. We were one of two sites. San Diego was the other site that you'll hear from my colleague in a moment, and very, very different models. In Contra Costa, we don't have a health information organization or health information or bi-directional exchange with the hospitals as of yet. And so basically the proof of concept was mostly integrating a button into the electronic medical record of our ambulance provider. They worked with American Medical Response, and their EMR is called MEDS. And basically it's almost like an app, you know, where you would push a button and it would search for basically if there was a POLST available at a call. Now, one of the things that came up for us is that, you know, how often is that going to happen? Well, we have about 800 cardiac arrests a year in Contra Costa County. And again, most cardiac arrests that happen in the EMS community, about 60% of those happen in the home. So, you know, we're really behind the curve when we're going into a home where, you know, there's a POLST that has been made available, but we may have very little ability for our field providers to access that other than to rely on the family. And I think one of the challenges that we'll be probably talking about is when the family calls 911, you have to remember that all these people are geared to saving lives, and they're going on a call with a mission to a cardiac arrest. And if you're calling us in, some of the challenges has been discussing with our community the workflows associated with switching that off and doing something completely different. And we don't always have the availability of a POLST form, or being able to have reliable information about where that is and then trying to read that in the chaos of the moment. And so lots of different challenges. But we also have about 9% of our cardiac arrests that occur in skilled nursing facilities and nursing homes. So that is an opportunity, I think, that we could work more collaboratively with the community in order to make that happen.
Thanks, Pat. Mark, do you want to talk a little bit about what's going on in the registry down in San Diego?
Sure, but it's kind of how did I get here to speak today? I've been in health information technology for 39 years, but just before I did that, 40 years ago, I was a tour guide and bus driver in San Francisco, so I've come full circle. Anybody do SOAP notes or know problem-oriented system? Okay, I worked with Larry Weed, who was the father of that, automating electronic medical records way back when. We used touchscreen. And I worked with some investors who were going to expand that, and they said, touchscreen, never happened. Nobody's ever going to use touch. So even the experts didn't know. Moving forward, I worked with a company called IDX and GE for almost 20 years. I was clinical product manager. And that brought me to San Diego, where I worked with Sharp Healthcare for about 3 years, helping do a whole clinical transformation down there. So I lived in San Diego. And then I started working with Health Information Exchange, and patient engagement. So I worked a lot with HIMSS on connected patients and health information exchange. So health information exchange in San Diego means that, let's say I was a UCSD patient and then I became a Scripps patient. If you go to Scripps, in your EMR, you query the HIE, it queries the whole community and brings back problems, meds, allergies, labs, discharge summaries, progress notes. All of that information in an integrated fashion. So fast forwarding to now, how do we leverage that for the EMS world? So we did a pilot called SAFER, where the paramedics in the field, this was a different pilot by ONC, so the paramedics can query the HIE from there and get problems, meds, allergies, encounters. So then when the California Healthcare Foundation said, how are you going to extend that for POLST? It was very easy because now we're just querying another node, which is the POLST registry. So that means that the paramedic, when they put information in, last name, first name, date of birth, and gender, it's going to pull problems, meds, allergies, encounters, and a POLST form if it exists, and put that right in front of the paramedic. And then the paramedic starts putting the data in, and it's streaming down to the ED. So the ED is seeing the same thing that the paramedic's putting in. Typing in, EKGs and vital signs are getting streamed down there. So that's the combination of SAFER and combination of getting the ePulse form. And we've been live on the ePulse part of that for almost a year and about 2 years on the SAFER part.
Thank you, Mark. Beth, do you want to talk a little bit about what you're doing in Sutter Health?
Yeah, so hello. I'm Beth Mahler. I'm a physician executive at Sutter. I lead all of our palliative care and hospital medicine critical care strategies and programs. And about 5 years ago, we started to tackle at Sutter. For those of you who don't know, we're about 24 hospitals, 50,000 or so employees, about 15,000 physicians, large Sutter care at home, home health, hospice agency, and a leader in advanced illness care. We have an advanced illness management program that we're very proud of, and it's contributing to our sort of broader palliative care, ambulatory community-based palliative care programs. And one of the truths that we were discovering, even though we're a large integrated system, we're on a single instance of Epic across all of our ambulatory and hospital settings, is that most of our patients, many of our ambulatory care clinic patients are not our hospital patients. About half of our hospital patients are other people, other organizations' patients. And we were having stories within our own system of our patients, even though we've spent $1 billion on an EHR, for us not to be able to share our critical forms around life-sustaining orders, so POLST forms, or just even goals of care, living wills, advanced directives, whatever. So we started to try to think about how we would build that on our own within Epic. Because UCSF, Stanford, other major healthcare organizations in the Northern California footprint are also Epic clients, we thought, well, we'll just leverage care everywhere to share these documents and work on interoperability, et cetera. But there is no HIE really functional in Northern California. And we quickly came across the reality that that would be harder to build than you would think, to build smart forms, keep them up to date, share them, et cetera. And so we actually learned from the Oregon experience and decided to go to a third party. This was before the ePulse registry pilot began in California. And Sutter, we signed on coincidentally with the vendor who was going to be, who was awarded the ePulse for registry for Northern California. So Vinca, you'll hear from them later. But so we went live as an organization using a third party to manage essentially our POLST documents, a single document for a large healthcare organization that we want to have it be eminently shareable. So we're trying to liberate first the POLST and then hopefully some of the advanced directives and living will content from our medical record into a place where others can get it, so that our patients who are going to other hospitals or EMS services, that those forms are readily available. And then when in our emergency rooms, our ICUs, other places that we can discover other people's pulse or from other organizations, healthcare providers. So it's been a long journey. Then it just is coincidental that, so we're acting now like an anchor organization for this pulse. We have about 300,000 records, I think, pulse forms up in the cloud right now. We're sharing them with ourselves because a lot of other organizations in Northern California haven't signed on yet, other than the Contra Costa County pilot groups. So we are very, very engaged and interested for other organizations to sign on to the registry so that we can have those documents where they belong.
Great, thank you. And interoperability will be one of the things that we'll talk about a little bit later on in our second panel, so I'm glad that you gave us a hint towards that. Abby, I'm going to turn back to you. As the evaluator, you alluded to trying to collect some of the lessons that we're learning about how difficult this is, what some of the barriers are. Can you talk to some of the, at least what you're learning about some of the business barriers or obstacles that people are having to overcome to stand up an electric pulse registry or electronic pulse forms?
Absolutely. Overall, I think a key takeaway is that registry readiness is really important. Having a database that is already populated with a number of pulse forms is really key, because unless you have patients' information already available, by the time you loop in EDs and EMS, they have something to query. They have results that will pop up. And pulse forms are they're more of a rare needed event. So in those rare circumstances, to get a 15% hit rate on a pulse form, that can be really dragging for the workflow, and then you'll start to lose kind of the confidence of the people who are accessing the pulse forms. So having a robust number of forms in the database ready to go before launching a registry is helpful for future success. Also, identifying champions within health systems as well as community champions that are there to take on leadership roles, to educate others, and to help move forward some of the POLST workflow needs is really important. Unless you have leadership involved and leadership there pushing forward, it's hard to get traction anywhere else. A key one that I think is going to be super important moving forward in California is education. And it's not only education about how to use POLST forms and when POLST forms need to be filled out, when it's appropriate, but also ongoing education down the line. Maybe an audit system to check for POLST accuracy and POLST appropriateness would be helpful, because I think we've all seen, I was in an advanced care planning session before this, and even within our medical communities, there's still knowledge that can be given to our healthcare providers. And there's still areas where it's not completely clear, what's the use of a POLST form and how is that different from an advanced directive? We see it in Oregon all the time, and we are continually educating our community and our healthcare professionals on when it's appropriate to use POLST. Customizing tools to each organization is a difficult barrier, because big healthcare systems and small clinics all have their own workflow in place, and they also have their own technology in place. And working to connect apples and oranges and pears all together is a lot of times difficult, and a customizable solution a lot of times is necessary. Also, I don't think that we will ever see paper POLST forms go away. I would say in Oregon, we are still seeing 70% of the forms that we get are paper forms. And I think if you eliminate paper forms, you're going to alienate a certain community, especially rural areas. And the demographic of patients that we work with, they a lot of times really enjoy having that tangible form. That said, POLST form quality is a huge issue. I believe in the pilot, up to 44% of audited forms in certain areas were incomplete. And that's, we see, physician signature isn't there, the date of signature isn't there, the patient name is illegible, or the date of birth. Like those required elements that are needed to have a valuable POLST form available aren't always there. Healthcare providers see a huge volume of patients, it happens. And when you're an EMS or an ED personnel and you're looking at a POLST form and you're continually seeing a form that, one after another, that isn't valid, you're going to start to lose faith. So being able to audit that system will be important. Funding is huge. This is all going to cost money, and where does that come from is a big question, and that's a big barrier.
So you're going to leave us with that one.
Yeah, good luck. See you guys.
Thank you.
There are definitely creative solutions, and I think California has showed that this is important, and I don't think there's going to be a problem getting to the next step after the pilot is finished.
Thank you. Beth, maybe you can give us a little bit of your thoughts on barriers or obstacles in the health system, especially in getting adoption and use of a registry.
Yeah, well, I omitted the part that actually, the other reason, so beyond sharing the documents, the other reason we went live is this quality issue, and that was essentially the driver for the funding, because, as you can imagine, my organization wasn't excited about spending a lot of money to manage a single form outside of a record that we had just spent and invested many, many millions of dollars on. So the quality argument is a good one, and it's very compelling from a provider perspective, from the healthcare provider organization, and I think also from a health plan organization. I think the quality of the POLST really, really matters, because it's useless if it has the wrong date, if it's not signed properly, if sections conflict. You've now spent a lot of human capital and human resource time, not to mention the emotional impact of rendering care that's not wanted, or not rendering care that's wanted, based on a bad form. So that was actually the driving way I was able to succeed at Sutter anyway to get. So we're live with the actual creation of the POLST on the e-form itself. So you sign electronically. You can't create it erroneously. So we're probably at the same. We still are uploading paper POLST all over the place, and we're maybe creating 300 to 400 of our 2,500 a month POLST that go up. But so a barrier to training, just new workflow. If any of you use Outlook or Epic or whatever, you don't use all the bells and whistles of any program, I promise. I know I don't. And it takes a while to learn the new tricks. But using quality as the way to engender physician buy-in, particularly to the workflow. So for example, for the first time, we're able to measure in the emergency departments at Sutter, how often, when someone comes in extremis, are the physicians clicking in to look for a POLST? We couldn't do that before because it was in our media tab and we wouldn't know what they were looking for in any case. So now we can actually do a quality and process improvement endeavor around awareness around looking for the POLST before you act. Same in the ICU. How many times were we creating POLST for people who were DNR in the hospital? How many times were we creating a POLST for people discharged with a new DNR order? Things like that we couldn't do before. So that's helped a lot with the barriers around, at least from the provider organization's idea of the cost of implementing a third-party solution.
Great, thank you. Mark, do you want to talk a little bit about the barriers from an HIE and community standpoint?
Sure, it's kind of expounding on what we've already heard, but in San Diego, we actually started a POLST work group prior to when funding happened to do the pilot. And I was running that, and it was very interesting because I wanted to get the organizations all hyped up and let's get going. And every time I said, so let's start talking to your people about POLST forms, all the organizations looked down at their feet. And I think, and finally John Tasted at Sharp Healthcare came clean and said, Mark, we're not ready for this. When we started analyzing what was going on at Sharp Healthcare, they created a Six Sigma project and cleaned up all of their act before they did, and now they're tremendous. All of their forms are coming in electronically. So they have a central place for all their forms. As soon as it hits the central place, it also goes to the registry. So they're a really good user. UCSD is doing the same thing. So getting the organizations ready, getting those forms electronically is hugely important. I don't want to diminish the technology because we worked with Stella to create the e-registry, but the organizational readiness is huge. Quality has been a problem, and somebody came to me and said, you know, there's a lot of bad forms in the e-registry. I said, a lot, that's not very quantitative to me, but okay, there's some forms in there that don't have good quality. And they said, what are you going to do about it? I said, it's not our forms. Those problems exist at the organizations already. And then it exacerbates. So we now have a feedback loop so that when a form comes through, it's checked and feed back to the organization and said, this is not a valid POLST form.
Thanks, Mark. Pat, you got us started thinking about how POLST works in an EMS environment. Do you have more that you'd like to talk about that scenario and the challenges and how to perhaps make it work in the future?
Yeah, the challenges I see as an EMS director fall into two buckets. Okay, one is the technology part, which can be overcome with a lot of funding and investment. I think San Diego's Beacon project was a $50 million or something like that. That's never going to happen in my community, okay, in terms of that level of effort. So we have to find different solutions. I'd like to say there'd be an app for that. But the most important thing is that the technology has to support the people who are using it. It's just, the technology is a tool. The tool is only as good as the people who use it, and that it can be reliable and draw down information that is reliable. And I think everybody's touched on some of the challenges associated with that. There's also gaps in the EMS world regarding, Wi-Fi availability. Even though many of the ambulances for the 911 have Wi-Fi associated with it, one of the things we identified is when they went into the home, they didn't have access for their electronic EMR to their Wi-Fi in order to do that. Now, having said that, that may get better with 5G. But 5G technology is also very controversial in a lot of communities, including mine, so associated with a lot of other issues. I do believe that you don't need to create a whole separate infrastructure for the technology to exchange information. I think you can do that purely with interfaces, but we have to remember that all of these EMRs and these platforms that we want to have talk to each other so it provides actionable information that is value and is able to be used effectively with the patient, really requires a lot of thought, and also, they're proprietary. They're proprietary. And because they're proprietary, it costs either a lot of money or there are business or political issues that are involved that get in the way of us being able to exchange information at the right time for the benefit of the patient. The other piece is the humanitarian piece because, we had a lot of concerns and our providers had a lot of concerns about how this information might change what they might need to do in the field, and would that be disruptive to patient care, and would they be making the right decision? Is it fair for an EMT or paramedic to have to make those decisions in the moment when they're called to 911? Why are the family calling 911 in the first place? I think we need to have a bigger conversation about what people need to do. Does it mean that the family wasn't fully informed of, the patient's wishes? Are they just scared? My EMTs and paramedics are not trained in palliative care, and to ask them to be able to support the family in that moment in a special way that is completely contrary to their training is a big ask. I think it's a big ask. It doesn't mean that they're not capable, and it doesn't mean that we don't want to do the right thing, because above all in our community, we value patient choice. And we want to honor those decisions that are made at the end of life that are so carefully crafted and decided with a lot of input from providers, and we don't want to get in the way of that. But having said that, if we are called to a scene where there is a POLST available, but we don't have access to it, I don't think all is lost. We can certainly provide an early alert that we have a patient coming in, that there was a POLST found en route as far as that's concerned, and then we can take the patient and their family can be in a more controlled setting with the supports that are in place. You have to understand what happens, at the scene of a cardiac arrest when we stop CPR and leave the patient there. We leave the patient in the home until the coroner is able to get there. That could be hours. If the family is not prepared for that, I think we need to really think about that full circle in order to do our very best work and honor their choices in the situation. So this is a complex issue, I think, and that can be handled well, but how do we get that orchestrated with everybody coordinated on the same page? That's the bigger task.
Thanks, Pat. So I've gotten the 5-minute warning. I'd really invite other people, especially if you want me to quit asking questions, to come up to one of the microphones and ask questions. Our panel has really got a lot of experience in trying to make this work. So, yes,
Hi,
please. Go ahead.
I'm Deborah, and this is for Pat. Just last week I had a problem with a patient of mine who has a POLST, lives in an assisted living, a small neighborhood board and care. This patient desires to have comfort-focused care measures, but had fallen and hit her head. She was not neurologically impaired in any way, but of course they have to call 911. And this was so distressing for the patient's family, for the board and care, and the paramedics were absolutely livid at leaving her there because she refused them at the door. But we haven't really talked about the assisted living portion of this, and that's a huge problem, I think, because of the regulations around Title 22 and the fact that they cannot stay in place, even though their express wishes would be to be cared for by the people who know them best, even if they were going to die.
Yeah, that's a great question, because the question is that people can call 911 for a POLST patient who isn't in cardiac arrest. They've just fallen, they've bumped their knee, and what do you do with that situation? And what does the family want to do? What does the patient want to do? Because they don't want to end. They're going to go and get that treated, and that's not going to end their lives.
Well, and it's a $2,000 ambulance ride, too,
Well,
for people on a limited budget. And that's another issue for some of them, especially when they have that
and
in place.
patients do have a right to, refuse transport, but again, when they're in an assisted living, you have that conflict between what is required under regulations and in that setting. Those things have to be reconciled, and it's not fair to ask the EMS system to do that.
It's a huge thing. We need to get together and develop, I think, better policies around it as a state. Thank you.
You had a question?
Grace Cordovano, board certified patient advocate. I'm seeing this bigger conversation and would love to hear your thoughts on how do we hold our Department of Education accountable in refreshing the core curriculum. These conversations are happening here and they're powerful, but we're in one room. They need to be happening earlier, perhaps at a high school, college level, where we can create a safe space for young adults to be proactive members of our healthcare ecosystem. So is there any work being done there? Because we can sit and talk all day, but it needs to happen earlier for this next generation? We can try to Band-Aid fix this now, but what about the next generation coming in?
I don't have an
So-
answer for that.
Yeah, I think for e-registries, that like we're kind of focused on the workflow and technology.
But I will say, so there's a large movement here in Northern California called EndWell, where we're reimagining the end-of-life experience. And one of the winners that came out of that was this idea of starting death education, the same way we started sex education with middle school and high school students, to start this conversation around mortality and death. And some of the lessons, Jessica Zitter is the leader, and then I don't know if the person from UCSF is here, but a colleague from UCSF, I can't remember her name, but 2 physicians are leading that work. And it's pretty powerful because the lessons they're learning are that, most teenagers, tweenagers, have experience with either a parent, a grandparent, a sibling, a friend, an aunt, an uncle dying. They know it, they experience mortality earlier, and they were, in the class pilots that they've done, have been playing the Go Wish cards going home then, and then being the vectors of, reasonableness with their parents, like, have you told us what you would want done? And they've started the conversations, and they're not scared of it really at all, because their curiosity quotient is so high, right? So it's a perfect example of, now that sort of the cultural, as we saw in the history of this idea of palliative medicine or mortality, or there's nothing intrinsically medical about dying anyway, so why don't we talk about it? I think that you're exactly right. It's more of a social movement than a medical movement, and it's trying to take it away, basically take it back from the medical care, societal expectation of what medicine is, and what we do, what we can do. So anyway, Death Ed is one example of, I think, the cafe culture is another.
Thank you. Last question.
Actually, I have a statement. It concerned me when I heard comments about EMS going and then that person needing it. The POLST is not an end-of-life comment. Right. It is also for choosing life. We can allow a natural death, but some people choose to not have a natural death, and that's why we transport them. So I hate to, we had in Ventura County, we had a church do a whole event around anti-POLST because they thought we were doing it as an end-of-life thing. So this is a really big thing to me to understand that this is not an end-of-life statement. This is a document that gives choice back to individuals.
I think Dr. Duncan said it really great in her advanced care planning session. Advanced care planning, including advanced directives and POLST, it's about living. It's not about death. So thank you for the comment.
All right. Well, I hope you'll join me in thanking our panelists. Thank you very much. We're going to move on. I'm going to ask Amy to come up, but while she's coming up to the stage, also if I can ask Doug, Ryan, Susie, and Carla to meet the first panel speakers over here and get your microphones on. A couple of times Pat alluded to that we needed to have a bigger conversation. I just wanted to take 1 minute and talk a little bit about the next steps. The pilot ended officially in December, and we're in the final stages of evaluation. But there are plans to take a look at what we should be doing in an electronic POLST registry moving forward. The coalition is going to be moving forward with, and I invite people to keep in touch with some of those activities. We're going to be convening stakeholders and working with the EMS authority to identify a vision for a POLST registry in California. We're going to be gathering the plans and large health systems and other stakeholders together to talk about funding. Funding did come up in our discussion today. We're also going to talk a little bit about what, from a technology and roadmap standpoint, what the future should look like. What is a physical POLST registry that delivers on what we need to do in California look like. We're going to be also then working with EMS authority in developing guidelines towards an electronic POLST form to accompany the paper form. So I would really encourage everybody to watch out for some of those activities as we're moving forward as well. While we take this little break between the two panels, are having Amy Vanderbroek talk to us a little bit from the National POLST Paradigm Office about what's happening with POLST on a national level. Amy?
Thank you. Good afternoon. Flip ahead. So I'm the executive director of the National POLST Paradigm, and I was asked to talk about what's going on with our technology consensus project. We started this in 2017 because I was getting a lot of questions from states about whether they should try to build their own registry, are we going to have a national registry, wanting to know best practices of integrating POLST within electronic medical records, and what are health information exchanges and how can they be used to help with POLST. We've also seen a lot of third-party vendors in this space trying to integrate POLST within their technology and their apps, and just either connecting with us or not, but we're just seeing this awareness of trying to connect with patients and families. So to find answers, and give the best advice, we felt that we really need to do this in an integrated way. So we felt it was important to include vendors and other people in this space and figure out what are they trying to do, what problems are they trying to solve, and how are they trying to solve them, while giving us an opportunity to really educate on the fundamentals of the POLST paradigm, try to establish a national registry ourselves, and determine what policies do we need and what do we need to be advocating for to protect the paradigm. So we had about 70 people that are currently involved with this. This is a partial list. At the end of the day, our mission is that all states have adopted the POLST paradigm, resulting in consistency of process, improved patient care, and greater patient control and direction over their medical treatment. And essentially that means that a patient should be able to get a POLST form in one state and be able to travel anywhere in the US and know that their form is going to be found and honored. And right now you can do that with a paper form, but it seems like technology would be able to make this easier. All states have some level of POLST paradigm. There's only 4 states that don't actually have a form out, but they've all been working on it. And as all the programs have developed, they've become more interested in registries. And this is the first registry map that we created, which was last year, where I asked, what is going on? And this is this year. It almost doubled in the number of states that are actively working to implement registries. So we know there's a lot of interest. But we are a national movement. And so the solutions have to be national in scope. No state is going to be successful on its own. And part of this consensus project is because looking at how we developed the paper form, we allowed states to do their own thing for a number of reasons, and it was great because a lot of innovation. But what we have today is 13 different names, 5 different colors, and there's multiple versions of the pink color. And we have a lot of different formats. And that is a challenge because it creates confusion. A healthcare professional who's used to looking at a pink teapot form might not look at a goldenrod La Poste form and recognize it's the same thing. And we all know that POLST forms are time-critical documents. You need to be able to identify what it is, be able to understand it and follow it, otherwise patients might be getting treatments that they don't want. And it's also been problematic from a public policy standpoint, from quality assurance, from research, and from doing education nationally to have these such variations. So what we said with technology is we need to stop this early and try to come up with consistent standards and guidelines so that states can implement the same way rather than having 50 different variations, which is what we have with a POLST form. So for example, one of the things that we're looking at is patient identifiers. This is the list of what states use, and so if we left it to the states to figure out their own, we would have variations of all this across the 50 states, and that's problematic. So part of our consensus is to agree on one version among the states, and then have that reflected in the national POLST form that we're working on right now, and then also share with ONC, the Office of the National Coordinator, which is very interested in this work. The project goals are, we wanted to develop best practices. We want to create a guide that all states can use about how to best integrate POLST with technology. We wanted to identify national priorities, what we should be advocating for at the national level and what's going to help states. We wanted to help align product development to make sure that they are in keeping with the POLST fundamentals. And then we wanted to evaluate what systems are currently out there so that we're not spending time and money to do something that could have just been done with the technology that's out there. So in 2018, thanks to many people on the stage and in this audience who sponsored it, we had a consensus conference, and we're having one in 2019, where we had 4 topic groups. So 55 people came, and they were divided into these groups. And then they talked about these 4 different discussion areas at length for about a day and a half. Right now, we've got a document at the 30,000-foot level. We actually got agreement on things, and then we identified what we wanted to work on this year. So thanks to the Network for Regional Healthcare Improvement, we have a private online group where we continue to share documents amongst each other. We're continuing the calls from last year in preparation for 2019. The hope is that we will have all of the materials and deliverables out by 2019, or the beginning of 2020. If you're interested, let me know. Otherwise, you can find information on POLST and technology on our website, and if you're interested specifically in the technology consensus, we have a specific page dedicated to that as well. So thank you.
Thank you, Amy. Well, we'll get right into our next panel. Our last panel, we were talking mostly about the business side of actually using a POLST registry. Now we'll switch gears a little bit and talk about implementations. There are a number of registries that exist within California today. And we'd like to touch on some of those to give you some insight into how they work. Joining me in our second panel up here today is Doug Kuntz, closest chair to me here, who's a senior project manager for Stella Technology, who created and operates the POLST registry in San Diego. Sitting next to him is Ryan Van Wert. I continually do that. Every time I say it in my head, I apologize for that. Who's the Chief Executive Officer for Vinca, who operates the POLST registry for Sutter Health and also in Contra Costa County for the pilot. Next to him is Susie Flores, who's the Director of Operations from Care Directives, operating a registry in the Central Valley. And finally, in the farthest seat is Dr. Carla Reyes with Health eMed Record. I'll start then, Doug, with you if you want to talk a little bit about your implementation at Stella.
Absolutely. Thank you. So I'm guessing we don't have a lot of software people in the room. I'm a product manager, and a lot of what I do is really try to talk with people, understand what their needs are, and then try to figure out how to translate that into a product that will actually meet those needs. So a lot of what I do is try to work with healthcare providers and understand what they're trying to do, and then go tell the engineers, here's what you build, and I think they won't hate it too much. And usually that works out. So for the registry in San Diego, when we came to it, we really started with one main objective. Earlier you heard a discussion in terms of readiness and is there going to be a critical mass of forms. And that was something that we identified right out of the gate in San Diego as something that we would want to address right away. So that was the prime objective, is trying to make sure that there are going to be enough forms in this registry that it is worthwhile to check. And so that was really our first point of attack. And we worked with a number of the organizations that are participating in San Diego Health Connect in order to try and get those forms. And our top source of forms actually thus far has been Sharp Healthcare. And in their case, what they have is they already had a good process in place for preparing their forms and implemented an automated feed sending forms to the registry. So for the healthcare practitioners out there at Sharp Healthcare, they didn't need to change what they were doing. They just continued working the way that they had been doing, and then once they put a form into their electronic medical record, it's getting sent to the registry. And so that allowed us to quickly build critical mass in terms of a number of forms. So that's the first barrier that we worked on overcoming, is having a critical mass of forms that people actually want to come and look at the registry. And then the next item is, when you get a form in front of you, is it a form that you can have faith in? So what's the quality of the form? And so the discussion in terms of organizational readiness and working with healthcare providers to make sure that they're completing the form validly is very much an ongoing conversation. I think that we've put processes in place in the world of paper forms to try and drive quality improvement there. But we're also starting to work on what we see as the next frontier there, which is electronic form completion, so that we can have validations in place and make sure that required fields are not being omitted, that the signature date is getting populated in automatically, that type of thing. So we're, in order to implement something like that, that's more of a workflow change, and I think going to be a bigger lift. So we're just starting to get our feet wet there, and starting to put a pilot implementation of electronic form completion in front of a closely monitored set of pilot users. And we're looking forward to hearing what their feedback is, what we got right, and even more importantly, what do we need to change and continue improving.
Thank you. Ryan, you want to share some of your experience at Vinca?
Yeah, sure. And by way of brief background, is everybody hearing me okay? Okay, excellent, thank you. I'm a critical care doc, one of the co-founders of Vinca. It was a local spin-out from Stanford in 2012-13. And a lot of what we do today is really driven by what we saw in the critical care unit in those days of seeing time and again people with existing life-limiting illnesses come through the doors of the emergency room, really no idea of that person's care preferences, and invariably that person would end up in the intensive care unit, often on a ventilator, and then a few days later somebody would show up with a crumpled up POLST form saying that they never wanted to be there in the first place. They hadn't had the conversation, or there was some kind of error on the form that made it unusable, and just saw that happen time and time again, where people were not getting what they wanted, and thought that there was an opportunity to leverage technology to standardize process, improve quality, and reduce variability for the entire process of advanced care planning. Is really, when you think about it, there's so many points of failure that can occur, from understanding a person's wishes, making sure it's codified and documented accurately, making sure it's updated, and making sure it's universally accessible, that if there is a single point where that fails, all is lost. And our approach has been to leverage technology to help healthcare organizations to streamline that process. An important component of that is the registry piece. And at this point, we've matured into really two different offerings, one of which helps the healthcare organization to implement best practices for advanced care planning, and the second is something that state-level organizations use to make sure these documents are universally accessible, version-controlled, et cetera, et cetera. And we're fortunate to support the Northern California Contra Costa County POLST registry pilot, and you heard Beth speak just now. A lot of that effort and momentum really was through Sutter Health's commitment to being the first to stand up and say, this is a really important initiative for the community, for all of our patients. It's the right thing to do. And to this day, Sutter in Northern California, as you heard was mentioned, several hundred thousand forms that are Sutter forms that contribute to that population aspect of the registry. Otherwise, within Contra Costa County, we address several other points of access, and the real goal of the registry is to balance universal access with HIPAA, essentially, if you can think about it in a very simplistic terms, is you'd love to be able to go to codestatus.com or POLST.com and look up somebody's POLST form. But we all know that there's certain regulations that prevent that from happening. And the balance is that user access management piece, making sure that the right people are looking at forms for the right patient at the right time, with making it clinically integrated in a way that people are actually going to use that form. So in the healthcare system, it's relatively straightforward in the sense that with the large EHRs, it's relatively straightforward to embed links, put dynamic flags so people know there's forms and otherwise. At the skilled nursing level, we developed a similar implementation with point-click care, which is sort of the epic of the post-acute world. And then you heard Pat talk a little bit about the work we did with American Medical Response on the ambulance and EMS pre-hospital side, and then a variety of other ways, e-fax and otherwise, that people could be submitting forms to the registry. And I would say the biggest learning from that is that the technology really is the easy part. And I think you heard there were several themes from the first group of panelists that this is all about awareness, adoption, people seeing this as a priority. And the real unique challenge of a registry is that you have so many different points of care where you have to do this whole process over and over and over again. Ambulatory, inpatient, ED, home health, EMS, assisted living, skilled nursing. And every single one of those areas needs an extreme change process, an organizational change process. And that's really the bigger challenge, I think, of implementing registries, is around getting to the front lines of every one of those spots and making sure that people are aware of and that they find it easy enough to use these valuable types of resources. So we're continuing our work in Northern California. We also developed a few years ago what we call a bidirectional interface with the existing Oregon POLST registry that you heard Abby talk about, and that was something, a really nice demonstration in the sense that they had an existing registry there, but we were able to show that we substantially reduced the error rates on forms by virtue of the digital completion, and we also doubled the submission rate of forms into that registry, which speaks to the fact that relying on somebody to fax a form in, is really not always going to happen. So a lot of benefits to leveraging technology to solve the problem of high quality advanced care planning and ultimately care concordance at the end of life with care preferences. But it really comes down to those registry, that front line of clinical stakeholders. We also have learned a lot now. We're in 3 other states in addition to California and Oregon on the registry side. So we've taken and constantly are learning more about how to solve this problem of broad dissemination of advanced care planning document availability.
Thank you, Ryan. Susie, you want to talk a little bit about what your organization is doing?
Sure. So Care Directives was born in, it started in 2014. I had another application for care coordination from acute onto lower level of care. And in presenting that application to a payer, one thing kept coming up in that 1-hour meeting was, why can't you do this for POLST? Why can't you slap a POLST form into this application and then share it from the hospital to the nursing home, to the physician's office and beyond? And that came up 3 times in less than a month at different meetings. And so we decided to do some research, find out what was happening in the space, learned a lot about what organizations like the National POLST Paradigm, the Coalition were doing, and some other technology vendors, and decided to build an application. Fast forward to 2017, we connected 2 neighboring counties in Southern California, which is Riverside and San Bernardino County, with 99% adoption across the acute care hospitals, about 75% across the skilled nursing facilities where it is a little more challenging, and we have about 2,300 community physicians and are working on EMS connection. In those 2 neighboring counties, we get about 100,000 queries a month at all levels of care. What we found is, how do we design an application that is fluid to different workflows, not just acute versus SNF versus the ambulatory side, but we have hospitals who have told us, we don't produce any POLST forms. The only time we use POLST forms is when the patient walks in with it. We have other hospitals, some that are here today, that have been huge champions of POLST forms and have been consuming and producing POLST forms for quite some time and had large backlogs of them and had really engaged their providers in educating them on the use of POLST forms. And so we set out to design a registry that was fluid, that could adapt to that hospital that only accepts POLST forms and can support the hospital that produces a lot of POLST forms. Same thing with skilled nursing facilities where technology resources are not as readily accessible. How do we support EMS where Wi-Fi is not accessible? So building a registry that can serve up that POLST form on a 2G network in under 3 seconds, whether it's a heavily populated area or in the middle of nowhere in Texas or some of our areas in San Bernardino County. And so being able to really push those documents back and forth, interoperability plays a huge role, but as Ryan was saying, the technology piece is the easier piece. It's how do we engage our providers to ensure that we have a registry that they will adopt and use and go to regularly.
Thank you. Carla?
Yes, hi. Carla Reyes here, Ventura County. I'm a practicing ER physician and a pediatrician. I'm also an attorney. which means I'm a little confused to begin with. But through years of medicine and law, I became very passionate about some of the things that I'm seeing in my ER, because ER is really the downstream, right? We talk about upstream. We are downstream. And we're catching all the fish, right? And we're seeing things happen that kind of creates moral distress. And I don't know an ER physician in this country that doesn't feel it. And so that was really the basis for where we started a company, Healthy Med Record. I'm also part of the Ventura County Medical Association and a steering committee member of the Ventura County Coalition for Compassionate Care. And so those collaborations allowed me to have interactions with our VCMA, our medical association in the county, and dream up whatever we wanted to do. Whatever a bunch of physicians got together and nurses and community leaders and said, what can we build? And so this was really a grassroots experience. And then lo and behold, we also heard about some pilots that were going on, So we felt that we were doing the right thing, and we continued to push hard. And so we talk about what are the real barriers in a registry. It really is engagement and inspiring people to do the right thing. Because I think once we got the support of the 40 or so odd organizations that are part of our coalition and the hospitals and EMS, then it made us feel like we were moving forward in the right direction. And that doesn't say that I'm not saying it's easy. It's actually very difficult. But one of the keys, I think, in starting a registry is finding champions. And it was mentioned in the last panel. You can find those champions that also agree with what you're trying to do. Then it makes it a little bit easier. So some of the things that we're doing in Ventura County is we're a little bit unique because not only are we doing the registry thing, but we're also a qualified clinical data registry. I'm presuming that most of you don't know what MACRA and MIPS is, but maybe you do. But physicians are becoming incentivized to report their quality metrics to Medicare and Medicaid services, to the extent that if they don't report it, then they're going to get penalized. And then each year that penalty becomes higher and higher. So we came up with the idea of, well, let's create our own quality metric, and that's submitting an electronic POLST into our registry, which is now recognized by CMS. So we're the only one in the country that has this capability of providing that additional incentive for providers, not only to tell them, look, you need to do the right thing, but you're also going to be rewarded for it. So it also kind of leans towards what our business plan is in terms of providing that additional incentive. So we're a little bit unique there. And it really comes back to this kind of grassroots approach that we started from the very beginning. So everyone that's involved in our company is devoted and very open to engaging with new collaborations. We just signed on with the Colorado statewide HIE, which has basically 95% reach of all the providers in Colorado, and we're actually implementing as we speak. So very proud of that. And there is distinct differences between an HIE county and a non-HIE county. Ventura County has no HIE. So all those barriers are just magnified times 1,000, And I know that now, because now with the Colorado experience, it's like, oh, I just connect with one platform. And then we can really just roll it out everywhere else. And that's literally what's happening. So understanding both barriers is really important. But again, at the very basis for establishing a registry is finding those champions.
Thank you. So the next question that I had written down to ask everybody was technical barriers. Well, I've had three of you say that technology is easy, so we're just going to skip that question. But a number of you have talked about the business barriers as well, and especially adoption. And Susie, if I can put you on the spot a little bit, you have very high adoption in the areas that you're serving. Can you talk a little bit about what it takes to get good adoption, good physician participation in a registry?
Sure. So finding that champion. The first person who said, why can't you do this for POLST forms? Why can't you add a POLST form to your exchange? Was a CMO at a Medicaid payer that manages 1.2 million lives in these two counties. And so after we built our registry and did our beta testing, we went back to that payer and said, here's what we built. We would like for you guys to partner with us in helping us roll this out. And within 10 minutes, they said we have to roll this out to all of our providers. And so finding that champion who really stood side by side with us and helped us engage their providers, from hospitals to nursing homes to physicians, and ongoing education for the providers was key in our success in being able to say that we have 99% adoption across all of the acute care hospitals in that area. They added it to their SB 1004 program, as POLST is very important in that program. So for their providers, as they rolled that out, accessing the registry and participating in the registry was a metric, a performance metric for the providers.
All right, thank you. And Carla, I don't know if you want to talk anymore. You have a little bit of a unique model that you already touched on in doing quality measures. Can you talk about adoption and how that is going in your area?
Yeah, so it's interesting because not only are we reaching out to hospitals and skilled nursing facilities, we're also reaching out to individual providers and provider groups, and we're focused on ACOs because all of a sudden providers are needing to focus on quality. So what our Qualified Clinical Data Registry does is it focuses on all those metrics that would be naturally selected by providers that deal with the POLST paradigm and having to further it in terms of patients during transitions of care with the chronic and terminal illness. So it was a very deliberate approach in terms of how we created our Qualified Clinical Data Registry. So because we're able to reach out to individual providers, first of all, it makes it a lot busier for us to really engage with so many people. But we stay grassroots. We stay kind of grounded in terms of that approach. But I think we really align with those champions that sign up and say, I want to do this, and I want to. And it makes it very easy for us to then engage those champions to help us further our approach as well. So that, it keeps coming back to that concept, but it's very key. And like I said, since we're not an HIE county, again, it's a lot of footwork. It's a lot of reaching out to administrators and really hitting the pavement, so to speak. But that being said, most of the country is not HIE. So I think with the help of National POLST and the help of the Coalition for Compassionate Care in California, it's something that we should discuss in terms of trying to find that business model that makes sense, that can be disseminated throughout California.
Right. Well, so I was just kidding. I would like each one of you to choose what you think is your top barrier to moving things forward, especially from a technical standpoint. If you would just give us a quick snapshot of what that looks like and how you might be trying to solve that. And Doug, maybe you can start us off real quick.
Sure. So as I mentioned earlier, I think that for us as we're looking towards electronic completion, it's exactly how do we find that sweet spot of completing the form electronically into clinical workflow, because people are already very used to doing it on paper. For the EMS use case, I actually think that we've addressed that very well, and it shows the power of workflow integration. That in San Diego, when an EMS crew is working on a patient, they don't have to actually go in and type in the patient's information and explicitly do a search in the registry. That's being done in the background for them. And if the patient has a POLST, then they're being alerted this patient has a POLST. And I would like to see exactly that same kind of ease of use or that kind of workflow integration with electronic completion. And that's exactly what we're trying to figure out is how do we really nail that so that it just feels like part of how you deliver care rather than a distraction from how you deliver care.
Thank you. Ryan?
I think it has been sort of touched on before, but I do think that a lot of the, I'll call it the long tail of healthcare on the technology adoption and implementation side, where there are very important users of POLST and advanced care planning registries. And it goes back to my comment earlier that this really comes down to critical user access management issues. So how do you let a home health nurse access a registry to submit or query a form, with all those use cases of them not having internet, all those other things that may come up in those care settings. And it may only reasonably be, call it, say, 20% of the user base of the registry, but it's a critical part of the registry. So what we've been focusing on and where we are actively working is in addressing those care settings where you don't have an Epic to tie into, you don't have a Cerner, you don't have an HIE, but you've still got some really important users out there. And I think that's one where, where from a technological perspective, there is a need to solve that problem from the user access management system in the setting of data privacy and security and usability.
Susie?
For us, I would say it's interoperability. We all have cell phones, but if we couldn't call each other, they wouldn't do us any good. And we found that that's healthcare interoperability, is how do we communicate with the McKesson users and the Epic users and the Cerner users. I'll say we became a Cerner-validated Fire app last fall, and we had health systems who found us in the Cerner app gallery who said, we have been trying to find a solution for this. So in terms of finding stakeholders and providers, folks are looking for a solution, but it has to be able to fit within their workflow, and it has to be able to communicate within the EHR. Thinking that a EMT or a paramedic is going to remember that there's this registry that they can log into and then put in patient demographics all in a 5-second window is not going to happen. It has to happen in the background where the EHR is integrated with the registry. It sends out a message. If a match is found, the form is pushed back in. The paramedic never even knew that this happened. It's like fairy magic. But a POLST form is there and it's accessible. So for us, it was really focusing on interoperability and being able to serve every provider that we have. I will say that we get our CTOs here, but we get several thousand manual queries that are done every single month where folks do log in and do that standalone access and do query because they don't have the resources to maybe do a more robust integration. But we worked with them on managing their users and teaching them how to access the registry and designing a workflow that allowed it to happen every single time at the point of care.
I totally agree, actually. Yeah, interoperability is the biggest issue. It's the thing that's trying to prevent this from happening, really. And interoperability is really multi-level too. It's not just the what's being shared or how it's being shared, but the protections that organizations and companies provide to prevent those interoperability links to occur. So it's not just technology that's contributing to the interoperability problem. So there has to be a paradigm shift in the way we share information. I mean, what we're all trying to do, everyone on this stage right now is trying to create a form of community chart. And that community chart needs to be shared and owned by everyone in this room. And that's what we're trying to build at the end of the day. So it is a paradigm shift that's going to change this interoperability problem and pave the way for hopefully creating standards in California so that we could build our products towards those standards. To me, it seems that that's the way we need to go.
All right, thank you. Well, we have a few minutes for some questions. If people like to come up and ask questions, it'll keep me from getting deep into the technology, and you don't want any of us, none of us want that. Please go ahead.
Hi there, Regina Reardon. I'm a registered nurse, critical care at a hospice. And one of the biggest obstacles that I've seen in terms of POLST is sort of like the end-of-life discussion. Why is this a HIPAA issue? Why is this a privacy issue? Don't we all, I ask you as the panel, everybody out here, don't we all want everyone to know, hey, I want you to do this, I don't want you to do this? To me, it's almost like part of that interoperability and part of that access. Take it out of that cloak of privacy of HIPAA and make it a more open conversation. So you're almost not really even having to access the record or go through, I don't want to, like, for all you technological people, I thank you, but to me it's like simplify this. If you really want this to be accessible in the community and for everyone to have that information, then take it out from this cloak of privacy that arguably it doesn't belong in.
Okay, go ahead, clap. One thing that I will say that a couple of us have been talking a little bit about, that this needs to be a bigger conversation. I think there is a good example. You know, I hear that comment in multiple places that requires a regulation change, and we need to be vocal about making sure those things happen. These guys, the Sutters of the world, et cetera, can't do it on their own. So we need to, as a community, start to get vocal if we really want that to change. Sorry, I had to step up on my soapbox there for a minute. Go ahead.
I'm Stan Turman, a psychiatrist, and it could be said that accessing the POLST is just the beginning, and interpreting it is what is key. And Fred Meraki published several papers, Triad, in which he showed that when there's a short video of at least 45 seconds or so, that the responses were more accurate on the part of the EMS personnel. I contributed a little bit to that study. So would that present a technological or a political, procedural challenge that you could not overcome?
I can start. I think you bring up a great point that, you know, if you're looking at a pulse form in isolation, you don't necessarily know what the context was around it. You're relying on it being a high quality form. And there have been many approaches to non-text-based documentation of future care preferences. I completely agree. And our approach has been to try and augment just beyond the pulse to say what other kinds of facilitated discussion can be supported, documented, codified. But I think, you know, for the clinicians in the room, that particularly those that function in more acute and emergency room ICU type settings, the more information you have, the better. You know, I think that's the bottom line, is the more of a picture you can put together about that person's choices as they've gone through a journey of life and disease process, it helps you to make that decision and counsel that person and their family about what care they want.
I 100% agree. As an ER doc, when someone comes in with a car accident, I say, did you take a picture of your car? Right? Because that's mechanism of injury right there. That gives me information that them explaining couldn't give me. So any tool that would assist us both in whether it's understanding what a patient's wishes are, or it's updating a POLST, or maybe it's clinical decision support, any of that would be helpful. So I think that repository should consider all those as potential tools in the repository.
He's pointing the hook at me, so if we can keep our questions really short, we'll try to, I'll steal a couple of minutes. So why don't you go ahead?
I'll try really hard. My name's Kathy Graham. I'm an EMT as well as a health informatician. I would say as an EMT, what I would like is sorry, here we go. Is that better? Okay. As an EMT, I would want to know about that POLST form as part of the dispatch feed. I want to know before I get on scene that I'm going to be dealing with this, I'm going to be looking for it, I'm going to be dealing with a family that is very upset. And having said that, I know most solutions don't provide that, but have we looked into some methods such as, I believe in North Carolina, they're using bracelets and sniffs that include the POLST form on them so that they can be looked up and you're not depending on Wi-Fi. You know, there are ways around some of the other technological problems, but you told me to keep it short. So I'd love to talk to you all afterwards, but NEMSIS is another good source of information that can be fed into this. That's the National EMS database. It's all the ambulance runs. So I agree with Pat that there's a whole discussion around what happens with that patient, but the other comment I would say alternatively is field resuscitation is brutal, and it's not something the family wants to witness nor see in the patient that's still going to be left there. And it is life-changing for the first responders that have to do this. They don't want to do this, but all we get taught is the form complete? Are the signatures there, the dates there? If not, you're in full resuscitation mode. And that's the way EMTs run. Our job is to get that person into the ER, and nothing stops us. As a master's student, I did a study and showed if you had a DNR, it was less than 10% made it to the ED. If you did not, it was 80%. but once they got to the ED, approximately 84% passed away in the ED. That's a bad situation. So it wasn't short, sorry, but thank you.
Rim, two quick things.
Real quick.
Two quick things. First of all, where is this all going? A lot of these were pilots, and now the whole state, CMS and CalEMSA, which is the California EMS Authority, they're all looking at dollars to make this more statewide, connecting the POLST registries and expanding them. And also there's a poster session that shows the EMS and what we did in San Diego.
Thank you, Mark.
That was short, Mark. I'm Carl Steinberg. I'm a past chair of this coalition. I'm also active with National POLST. And thanks for all the great work you guys are doing. It's innovative and it's really needed. I just felt like I had to comment every time I hear something about POLST forms being incentivized, that makes me really nervous because we see so many POLST forms being done, like in nursing homes, on residents who are totally not POLST appropriate, where it's being used as a code status document. We don't want it to be that. Those people don't, if they want to be full code, if they're normal, reasonably healthy people who just had a hip replaced, they totally should not be doing a POLST form. And so I just wonder what you guys might have to say about that.
Can I comment on that? Our registry actually manages every type of advanced care planning document. So durable power of attorneys, living wills, durable power of attorney for healthcare, living wills, advanced directives, at a hospital DNR forms, and POLST forms. And part of the education that we do is that we engage providers on who is POLST appropriate and who's advanced, and when should an advanced directive be used. We also have nursing homes that have submitted POLST forms that are 10 years old and have not been updated or modified, and we engage them on whether or not they're having ongoing education with either the family or the resident directly, so that they can update those care wishes. If the care wishes haven't changed and they're having those conversations, that's great. But if they're not having the conversation and the POLST form is 10 years old, then there might be an issue with that. So we certainly engage on that front.
Yeah, probably if it's 10 years old, they probably weren't POLST appropriate when they first filled it out. Now, maybe they're POLST appropriate now, right? That's the conversation. That thing ought to be shredded.
So if I could just say, our measure is written in such a way that saying that someone's not POLST appropriate qualifies for the measure. So it's not rewarding filling in a POLST, it's rewarding initiating the conversation.
That's a relief. Okay.
Well, join me in thanking our panelists. Thank you very much. And I appreciate your attention.